Hey, good afternoon. I'd like to welcome you to the second annual IPHA Student Research Symposium. My name is Beth Squires, and I'm the co-chair of the student section. And the section is really excited to have some more presentations from students all around the state of Illinois,
Some
although
people
you're
have
really
their
represented today.
their
But we're
thing
so
going
happy to
on.
have everybody here
Might
and
be me.
learning about the research that's been done. Just a friendly reminder to please mute yourself if you're not speaking. You're welcome to keep your camera on if you'd like. We'll be first hearing from Priya Mathur. And so please correct me for the correct pronunciation. Priya is a student at the University of Chicago, and she'll be sharing her research on the evaluation of PrEParate, a Latina AX-focused social marketing campaign. So Priya, the platform is yours.
All right, thank you. I'm just gonna share this and make it full screen. All right, hi everyone. My name is Priya Mathur, and I'm a master's in public health student at the University of Chicago. And I'm currently working with Dr. Haritha Shah and a group of community partners on the evaluation of a social marketing campaign for Latino individuals called PrEParate. So before I talk about the PrEParate campaign itself, I want to frame the issue of HIV incidence within the national and local context. So as many of us know, HIV is human immunodeficiency virus, a virus that attacks the body's white blood cells and the immune system, interfering with the ability to fight infection and disease. Untreated HIV can lead to AIDS, a lifelong condition with no definite cure. And HIV is spread primarily through sexual contact and injection drug use. In 2019 in the United States, there were an estimated 34,800 new HIV infections, with 29% of them occurring among Latino individuals. And importantly, while HIV incidence decreased or plateaued for most populations, young Latino men who have sex with men between the ages of 25 and 35 and Latino transgender people were two of the few subgroups for whom HIV diagnosis increased between 2014 and 2018. So MSM and transgender individuals were a particular focus for this intervention. And to put this in a local context, the Chicago Department of Public Health has created this map showing rates of HIV infection by community area and a chart displaying these rates by race and ethnicity. And we can see that the red and dark blue sections of the map with higher rates of HIV infections are located generally on the south and west sides of Chicago, corresponding to locations where higher proportions of Latino individuals live. And this chart on the right shows that Latino individuals comprised about 20% of HIV infections in Chicago in 2019, which is almost double the percentage for white individuals. And this brings us to PrEP. So in 2012, the Food and Drug Administration approved the first PrEP medication for HIV prevention. And today there are many options to access PrEP, including Truvada or Descovy pills or a long-acting injectable form of PrEP. Ultimately, PrEP is a highly effective preventive medication intended for HIV-negative individuals to prevent HIV transmission. And this CDC chart demonstrates that just 16% of Latino people in the US who were eligible for PrEP in 2020 were prescribed it, showing that unequal PrEP coverage persists. So knowing that PrEP is highly effective and available, and that Latino individuals at risk for HIV are not accessing PrEP as much as they should be, this project aimed to increase PrEP awareness and uptake among Latino individuals, particularly men who have sex with men and transgender people. So in 2016, a social marketing campaign called PrEP for Love was launched across Chicago to increase awareness about PrEP within Black populations. And these black and white images on the left-hand side of the slide were some of the materials used as part of that campaign. Social marketing campaigns use the application of commercial marketing principles to design and implement programs to affect health behavior change, often through social media and online and offline advertisements. And so this social marketing campaign of PrEP for Love was hugely successful, reaching millions of individuals and demonstrating that people who saw the campaign were more likely to initiate conversations about PrEP with providers, and disclose being on PrEP to loved ones. So this PrEParate campaign was evaluated, that I evaluated in this research, was adapted from the PrEP for Love campaign and tailored to Latino individuals in Chicago. And in addition to being a social marketing campaign, the PrEParate campaign also emphasized principles of community-based participatory research, which means it equitably involved community partners throughout the research process and facilitated empowerment of marginalized populations. So on the right-hand side, you can see some of the PrEParate materials. And from 2016 to 2021, several Latino community-based organizations generated ideas for this Latino-focused social marketing campaign, and they created the name and vision for PrEParate. And when adapting this campaign, community members wanted to maintain some of the images of real diverse community members and a sex-positive approach, but they also wanted to emphasize an English and Spanish component and more color. Local artists, graphic designers, videographers, and health activists supported the creation of this campaign content and distribution. Some of the individuals on the right served as ambassadors for this project, and so they shared their stories of living with HIV or being on PrEP and helped create some of the content. The virtual content was displayed through paid advertisements on Facebook, Instagram, YouTube, dating applications, and social media pages of Latino health-focused community-based organizations. And then physical content was also created as posters, flyers, Chicago Transit Authority bus and train advertisements, and giveaway items. And this campaign was launched from April to September of 2022. So after the campaign was launched, there are several pieces to the evaluation. So reach is being measured through social media metrics on Facebook, Instagram, and the centralized website. But in this presentation, I'll be presenting results from the surveys, which were used to assess demographic information, PrEP awareness, PrEParate exposure, and the motivational PrEP cascade. So the image on this slide shows the motivational PrEP cascade, which is a model demonstrating a series of 5 steps of engagement with PrEP, and it's based on the trans-theoretical model of health behavior. The surveys that we collected from Latino adults 18 and older across Chicago were collected through social media recruitment and in-person recruitment through community-based organization outreach, mostly with Project Vita and Calor. And from November 2022 to March 2023, 261 surveys were completed. So for some of the results, 2 key metrics that we measured were PrEParate exposure and PrEP awareness. So of the 261 individuals surveyed, 40% reported seeing the PrEParate campaign. And of the people who saw the campaign, 93% reported being aware of PrEP. And in the graph below, we compared the proportion of people aware of PrEP based on if they saw the campaign or not. And we found there was a significant difference in the proportion of PrEP awareness based on PrEParate exposure. Another key metric that we were interested in is the number of individuals in each stage of the behavior change model based on their exposure to PrEParate. So the 4 stages we looked at here based on the motivational PrEP cascade were pre-contemplation, contemplation, preparation, and action. And for this analysis, we only included the 181 survey respondents who were categorized as PrEP candidates, meaning they had more than 1 sexual partner in the last 3 months, or have used drugs other than alcohol and marijuana more than once in the last month, or identify as transgender or as a man who has sex with men. So the dark blue bars show the number of individuals in each stage for people who saw the campaign, and the light blue bars are the number of people in each stage for people who did not see the campaign. So looking at the number of individuals in stage 4, which is the action stage, we found there was a significant difference in the number of people on PrEP based on exposure to PrEParate. And one important thing to highlight here is that this was a cross-sectional survey, so we cannot report on how the number of individuals in each of these stages has changed over time. But we do know that of the 104 people who saw the campaign, 12 of them reported being directly influenced by PrEParate to start PrEP. So ultimately, there are two main takeaways from this work and a few next steps. One takeaway is that social marketing campaigns rooted in community-based participatory research can effectively promote awareness and directly encourage behavior change. However, because this study was cross-sectional in nature, we were not able to establish causation. So next steps for future work might be to do a prospective cohort study or an RCT. Additionally, we are currently determining what social determinants of health may impact PrEP access and HIV outcomes to guide our next intervention. And the second major takeaway from this work is that engaging Latino community-based organizations, activists, artists, and public health practitioners can help effectively adapt health communication for Latino audiences. So some of the next steps for this project are going to be conducting qualitative interviews with survey participants and community partners to assess acceptability, appropriateness, and implementation of the campaign. And that is everything that I had to present, but I wanted to take a moment to thank my principal investigators, institutional partners, community partners, and funders for their support in the creation and evaluation of PrEParate. Thank you for listening.
Great, thank you, Priya. Fabulous presentation. Do we have any questions for Priya?
I have a question.
Yeah.
Wait, sorry. Hi.
Hi.
I was just wondering, you might have mentioned it. Did you assess if they had exposure to any other types of campaigns related to PrEP versus PrEParate particularly?
We actually did not ask that in the survey question. But I think that might be like potentially people have brought that up in interviews or qualitative forms of evaluation, but we didn't actually ask that in the survey. The survey was kind of more demographic info and then their PrEP awareness, exposure, interaction, and then just one question about PrEParate exposure.
Okay, all right. Thank you. Great presentation.
Thanks.
Yeah, and there's great, make sure you check the chat. There's some great feedback too for you, Priya. And I just wanted to point out, I mean, great job. And it shows how this research leads to other research, so to encourage everyone to just get started because it's amazing how then a domino effect starts because I'm really curious to see that because of, unfortunately people don't recognize HIV as a very, as an up there, like, COVID-19 became everything, but HIV is still really scary, and so there is all this work going on to try to reduce it. So thank you. And, make sure to share your thank you with all the funders and your research partners and everything. So one more last opportunity for Priya, for questions for Priya. If not, I'd like to introduce our second presentation from Jesseca Pirkle. She is a fourth-year medical student in the University of Illinois' Rockford Campus College of Medicine's program, and she's actually a rural medicine student. And so she'll be sharing her research on pediatric dental coverage, our current efforts fixing the disparity. So Jesseca, the floor is yours.
Hi there. So as she said, my name is Jesseca Pirkle, and for at least the next 2 days, I'm a fourth-year medical student at the University of Illinois in Rockford, and I'm part of the rural medicine program. And today I'm going to talk to you about pediatric oral health trends in the state of Illinois. I'll start by introducing the topic, outlining some current efforts, then I'll go into our assessment and kind of some implications that can be taken away from it. And of note, this project was funded by the National Center for Oral Health, so I just want to put that out there as well. So let's dive in. So oral health is an integral component to all health and overall health. And if you think about it, oral health impacts what we can eat, what we can't eat. It's our first line of defense in terms of our immune system, and it helps us communicate. So it's crucial to begin taking care of our oral health, especially early on. And this includes going to the dentist at the age of 2, or brushing your teeth as a child, not drinking a lot of sugary foods or drinks, basically all the things kids hate. And so, but it's incredibly important. So, however, children the most common chronic condition noted in children are dental caries or this tooth decay. And this can cause, if it's continued to be left untreated, it can cause pain, school absences, difficulty concentrating, poor appearance, and overall, this can affect the student's ability to succeed academically if they're missing school, and even socially in terms of that poor appearance, it can mess with their self-esteem very early on. In the state of Illinois, children living in poverty are 5 times more likely to have fair or poor oral health in comparison to children who are not living in poverty. And many barriers that have been found are limited access to dental providers and cost, which if you think about it, this isn't really a surprise, right? Many studies have shown access and financial barriers to be significantly hindering access to all types of healthcare. And dental care, unfortunately, is not unique to these detriments. And so when we talk about access to dental providers in Illinois, access to oral health care in rural and underserved areas is an extreme detriment. In fact, the Illinois Department of Public Health has categorized 75 counties of the 102 to be categorized as health professional shortage areas. And really what this means is a health professional shortage area. It takes into account primary care, dental, and mental health providers, and looks at the number of providers in comparison to the relative population. And so 75 out of 102 counties being categorized as this is really a huge percentage of our state population. And so given the fact that these access to providers isn't anything new, Illinois has began to take initiatives to try to increase access to these rural areas. And by doing that, they've started doing loan repayment programs for dentists as well, and offering tax incentives for individuals who are willing to go and practice in these areas that may not be home to them, but are incredibly, but have people who are just also deserving of care. And then in terms of financial barriers, so the Affordable Care Act required Medicare or Medicaid and the Children's Health Insurance Program, which I'll refer to as CHIP throughout the rest of this presentation, to offer dental services. However, nationwide data suggests that children utilizing CHIP and Medicaid for dental coverage are actually 5 times more likely to have fair or poor oral health in comparison to those who do not utilize these government insurances. So this suggests that there is somewhat of a disconnect in terms of the steps that we have taken in order to really overcome these detriments in oral health care for these children in Illinois specifically. And so we really wanted to look at that. So the goal of this study was to really assess coverage patterns amongst licensed dentists in Illinois counties. And so when we went to create this study, it's not as simple as going and to every single county and finding every single dentist office and asking them what their insurance they took and stuff like that, because that would just take way too much time, and I don't think I'd be able to track down everyone even if I wanted to. So we found 3 really reliable sources, one being the National Plan and Provider Enumeration System, also known as NPPES, which basically every dentist who is applying for a NPI number or that National Provider Index number needing to prescribe will be found in that system. And that system also reported provider address and kind of like their specialty. Then, so that's where we went to look for all the providers in the state of Illinois. Then we also went through insurekitsnow.gov, which is a government website that displays every dentist who is participating in CHIP and Medicaid. And then they also provide the address and the taxonomy, so we made sure to cross-reference that as well. And then DentaQuest, we really wanted to see if providers weren't taking Medicaid insurance or CHIP, what were they taking? And so we also spent a little time in that as well. And so to start, I'm going to first start about talking about the number of dentists that we found in the state of Illinois, and to just kind of allocate or make you aware of the graph to the right. The darker colors mean more providers in that area. So you see a large population of dentists residing in more of the Chicagoland or suburb area, and fewer dentists residing in or practicing in the rural areas. And so we found 9,242 dentists that were licensed in the state of Illinois. 10 of counties in Illinois were found to have 0 licensed dentists in this area. And 29 counties were found to have less than 5. And if you look at the graph, a lot of these counties are in either Southern Illinois or Central Illinois, away from like the larger areas like Bloomington, Normal, or Urbana-Champaign. Really, they are they're kind of deserts, or dental deserts, as you may call them. And so when we looked at the dentists who accepted CHIP insurance, again, the graph on the right, the darker color, so the red color in this instance is more dentists accepting CHIP, and the lighter color is less dentists accepting CHIP. And we found 72 counties actually did not have a single licensed dentist professional participating in CHIP coverage. And of all rural counties, so all counties that had a certain population, only 4% of those dentists actually participated in CHIP. And again, you see a large disparity in those Southern and Central Illinois areas that of providers who may not be there or may not be accepting CHIP coverage. And then again, for the Medicaid, again, on the right, you see the darker green, so that forest green has more providers, as opposed to the lighter green has less providers. And again, you see the larger congregation in the urban or suburban areas, and then fewer congregations in the rural areas. And we found 14% of licensed dentists participated in Medicaid. 61 counties in the state of Illinois did not actually have a dental provider participating in Medicaid coverage. And so while financial assistance is a major initiative right now for the state of Illinois to really increase access, which is really important, as we saw, there were so many counties that didn't have adequate number of dental providers. Legislation has also moved to trying to increase access in terms of expanding legislation. However, dentists are actually not required to participate in CHIP or Medicaid insurance. And as we see here, a lot of them don't. And so the question is if we are spending our efforts to increase funding for these individuals who move to these areas, but they're not willing to accept Medicaid or CHIP insurance, given the fact that either there's a low reimbursement rate. For Illinois specifically, Illinois reimburses 46.8% and compared to private insurance, which is significantly lower than the national average of 61.4%. And then accepting Medicaid and CHIP also has a higher administrative burden, meaning there's a lot more paperwork that needs to be filled out in order just to get their reimbursement rates. So as the state of Illinois has spent their efforts to increasing access, which is also incredibly important, if the providers do not accept CHIP or Medicaid insurance, is that solving the problem, especially for these lower income and lower socioeconomical families, or is it just kind of further exacerbating a wealth gap, basically? And so that's kind of what we think needs to be investigated further, is really understanding all that goes behind Medicaid and CHIP participation. So dental insurance is separate than medical insurance, so as a primary care provider, as a insurance provider. And so it's there could be different barriers that have not been outlined in the medical insurance literature. And so understanding what all goes into the thought process of accepting Medicaid and CHIP insurance and not versus not. And then also, in order to increase access to these lower income and rural areas, I think state legislation should start to diversify their oral health infrastructure, meaning that whether it's increasing their funding for FQHCs in these areas that provide dental services as well and get larger reimbursement rates, or whether it is providing mobile clinics that come out to these areas and in these deserts that don't have any dental providers there, or even something that's becoming a little more popular in these lower income areas are school clinics. So whether these clinics generally have a physician or a nurse, and then also a dentist will also come out once or twice a week. And that really cuts down on not just the financial barriers for the parent, meaning that like they don't have to take time off from work. They don't have a transportation barrier. The kid is able to see and get their healthcare in their schools. It's also ensuring like close follow-up and that the kid actually has everything that they need in order to have a jump start on life, right? Because if they don't really take care of their oral health well early on, there's not a lot of room for improvement later. And so that is kind of all I had for there. I just want to thank the National Center of Rural Health and then my PI that kind of gave me this project, Dr. Hannah Hinkle, here at the Rural Medicine campus and University of Illinois. Those are my references, and thank you. And any questions?
Yeah, great job, Jessica. Scary, those are scary data when you see all the numbers and see all of those dental deserts. It's incredible to see that. So any questions for Jessica? I'm curious, has in the research, do you know, because I know there have the dentists, I'm thinking one next step could be if maybe the dentist could be contacted on their impact, their perspective on how to reduce that gap.
Yeah, I think that's a really important. I think that as I have these two sides, right? I'm a dual degree student, so I know the medical side and I have the public health side. And as a public health professional, I want to fix it all, but also, and I have these ideas that I want to fix it, but also knowing the logistics of the medical side, that like some of my ideas may not actually be feasible in practice. And so I think that having their perspective and understanding that side of it is going to be really important, because we can give them funds for whatever, but is it really going to solve the issue? And so I think that it's really important to have stakeholders involved in our decisions.
Right. Well, and also too, it is interesting, this is something I've observed as just, someone who has health insurance and then dental insurance. And I'm lucky I have good dental insurance coverage, but it's still not as extensive as my health insurance for my other, and so it is a major cost burden. And so the fact that dentists aren't required or mandated to, enroll in Medicaid and CHIP, I think is a disadvantage. And I can understand the reasons why, but you can see how policy kind of rules all.
Yeah. It's also interesting thinking about it. Like if you think about it, if there's like 5 dentists in an area and one decides they're all of a sudden going to take CHIP and Medicaid, that's all they're going to get, right? And then that cost burden isn't necessarily like it's not financially stable for them they can't live off of all of CHIP and Medicaid unless they're part of FQHC or get some extra funding there. So it kind of defers people away from going that direction, even if that's something they want to do just because it's not feasible.
Right.
Yeah, Jessica, just an interesting observation. As a rural family medicine provider, you mentioned, the school-based clinics, and those are very great. They do that in our area down in LaSalle, Peru, but we don't capture those children with dental caries until they're in kindergarten, and we miss those opportunities to address oral health earlier. So for example, in my rural health clinic, we start with fluoride treatments in infants at 6 months of age and do those every 3 to 6 months with their well child visits until they can be at the school-based clinics at kindergarten. Even though you mentioned starting to see a dentist at 2 is recommended, the other problem we have is that the general dentists in rural areas won't see children that young because, as you know, it's difficult to get a look in a kid's mouth and do much with them. And Medicaid is definitely a barrier as well because, a lot of the dentists won't take Medicaid, and those who do sometimes won't start seeing children until they are school aged. So lots of barriers, of course. And it was interesting to hear your presentation. Thank you.
Thank you. I also think that, especially in rural areas, just the education component is really key, especially for parents, and understanding that oral health is really just as important as physical or mental health like that. So I think it's cool that you guys incorporate that into your clinic as well.
Well, thank you. Again, great presentation, Jessica, and make sure you check out the chat. So you got some great kudos there. And then our last presentation is from a group of students from the Illinois Institute of Technology. We have Jazmin Sims, Julia Honda, and Grace Vestuto. And so, ladies, the floor is yours.
All right, well, hello everyone. I want to thank you so much for joining us today. Today, we will be presenting on LGBTQ identity labels and their effect on minority stress. My name is Jazmin Sims, as Beth just mentioned, and I will be accompanied by my co-authors, Julia Honda and Grace Vestuto, and collectively we are representing the Illinois Institute of Technology with contributions made by our instructor, Dr. Dubois. So today's learning objectives will lead to the understanding of increasing one's knowledge of current self-reported gender identity labels, as well as understanding associations between biological sex, gender identity labels, and minority stress-related variables, as well as discussing policy-level implications of these associations. So delving into a little bit more of the background, LGBTQ identity, self-reported gender identity labels are often used to describe an individual's gender presentation, which include labels such as femme, twink, androgynous, butch, jock, and bear. These labels serve important functions related to self-expression, identity, and community connectedness. Now, relatively little is known regarding these specific associations between self-reported gender identity labels and the congruence of these labels with assigned birth, sex, and minority stress-related experiences of those using those labels. Throughout the study, we utilized a minority stress theoretical framework, which is used to describe the discomfort experienced based on one's minority status. So specific experiences of minority stress include internalized homophobia and felt stigma, as well as being recognized as an LGBTQ member. This specific study examined associations between self-reported gender expression, felt stigma, and being recognized as an LGB member among a sample of LGB participants from the Generation Study. Okay, in an effort to find supportive evidence within the literature, we found articles discussing heteronormativity, which is defined as a cultural acceptance and understanding based on the assumption that men are romantically and sexually attracted to women and women feel the same to them. In all, this concept assumes that heterosexuality is the preferred norm in society compared to other orientations, and those who occupy those orientations are experiencing a lesser form of acceptance or acknowledgement. In that research, we found that current prevalence rates estimate that 7.1% of adults within the United States do identify with LGBTQ identities. And that led to further research finding that rates of internalized homophobia, stigma, and prejudice can predict higher psychological stress in gay men. That was found by Myers in 1995 and other researchers. Research also indicated that stigma, consciousness, sexual identity distress, and heterosexist experiences relate to higher levels of distress as well. And visibility management relates to poor social cohesion, depression-related stigma, and higher rates of distress. When we decided to use the minority stress theoretical framework, that was found through research that was originally developed by Brooks to discuss how stress affects the minority condition of lesbian women by occupying two minority statuses, both as a sexual minority and a gender minority as a woman. The intersection of these double marginalizations amplifies stress rates based on opposing forms of discrimination as two minority statuses. LGBTQ adults and youth report higher prevalence of mental health problems compared to their cisgender and heterosexual counterparts due to chronic stress related to discrimination on their identities, victimization, including assault, social rejection in interpersonal settings, and self and identity concealment. So within the present study, minority stress theory was used to describe how the self-reported gender identity labels within the LGBTQ community can relate to health and well-being.
Great. Thank you, Jasmine. Now just to go over a little bit about our data set, we use Generations data set from the Institute for Social Research at the University of Michigan. And the data was collected from 2016 to 2019 in a longitudinal study. The total sample size was 1,345 participants, and it assessed constructs such as healthcare access and utilization, social support, and other health outcomes. So moving on to kind of how we use the data, the inclusion criteria for the study was adults ages 18 to 60 in the United States who identified as lesbian, gay, bisexual, queer, or same gender loving. That they completed education until at least 6th grade and spoke conversational English, and then that they identified with at least one of the self-reported gender identities that we explained earlier. So that includes femme, twink, androgynous, butch, jock, and bear. And we got a total of 523 participants. The age breakdown was from 18 to 30 at 46.7%, 31 to 40 at 21.2%, 41 to 50 at 2.8%, and then 51 to 60 at 29.3%. Race and ethnicity breakdown, this was actually one of our controlled variables due to just like how our the minority stress theoretical framework. So we found that there was a 64.4% of white people, and then 15.5% at multiracial, 9.9% as Black, and then 9.9% at Latinx. And then the sex assigned at birth was 51.1% female and 48.9% male. So for this analysis, we used these variables within the data set, assessing biological sex and gender expression to create new variables, indicating whether a participant's gender expression was congruent or incongruent with their biological sex. So this means an individual reporting male for biological sex and jock for self-reported gender identity was coded as gender congruent, while someone reporting female for biological sex and butch for self-reported gender identity was coded as gender incongruent. So we hypothesized that individuals whose gender expression was incongruent with their biological sex would report higher levels of felt stigma and being recognized as LGB than those whose gender expression was congruent with their biological sex. So incongruency and congruency are based off heterosexist frameworks and associated expectations. Just a little bit more about our measures. So our IV was gender presentation congruency, while our dependent variables were felt stigma, which included 3 items. Most employers where I live will hire openly LGB people if they are qualified for the job. Most people where I live would not want someone who is openly LGB to take care of their children. Most people where I live think less of a person who's LGB. And then recognized as LGB. So being recognized as LGB is an original measure by the Myers study, the generation study, and they include 1 item, which is how often, if ever, can people tell you are LGB, even if you don't tell them. So for this analysis, we used a multivariate analysis of covariance, MANCOVA, to assess relations between our IV and multiple DBs.
Thank you, Julia. In terms of our analysis with what we found, well, first looking at our independent variable, we found that 55% of participants reported gender presentation identity labels that were congruent with their biological sex, and about 45% that were incongruent, so a fairly even split there. In terms of our measure means in general in both groups across the board, people rated how often they are recognized as LGB as a mean level of 3.34. With this scale, 1 was always recognized and 5 was never. In terms of their felt stigma scores, there was a mean response of 2.72, where with the items presented, 1 was strongly disagree and 5 was strongly agree. In terms of the results that we found from our MANCOVA, we found a significant difference for felt stigma, where those who were incongruent with their gender expression and their biological sex had higher levels of felt stigma than those who were congruent. So incongruent had a mean of 2.84, while those who were congruent were down to 2.62, and this was significant at the 0.05 level. For our next results we found, it was in terms of how often you are identified as being LGB, even if you don't come out yourself. And we found that those who were incongruent with their biological sex were recognized as LGB more often. So again, with this measure, 1 was always and 5 was never. So the lower the number, the more often they were recognized. So those who were incongruent had a mean of 2.86, while those who were congruent had a mean of 3.73. And this was significant at the 0.001 level. In terms of what these findings mean, this connects back to the research that Jazmin introduces at the beginning, but it really highlights how labels and appearances within the LGBTQ+ community relate to experiences of minority identification and minority stress among those using those labels. So LGBT adults whose gender identity presentation labels are congruent to their biological sex may be experiencing higher levels of felt stigma and a higher frequency of being recognized as LGB, even though they don't come out, compared to their counterparts. These findings provide evidence similar to the results found by Keller in 2009, and they researched findings that they found stated that identified identity labels commonly used in the LGBT+ community can predict certain factors of perceived psychological distress. So people belonging in the LGBTQ+ community developed an understanding of society's negative attitudes towards people who are non-gender conforming. Such work that we've looked at is discussed in a recent minority stress review by Hoy and Ellis in 2023. They looked at how LGBTQ populations experience significant health disparities. And it was kind of a review of all minority stress research in recent years, which again is the framework that we're looking at our results through. When it comes to future research, we would like to see more empirical studies that examine this relationship and look at some potential moderators that may be going on. So we would like to see internalized stigma as a mediator between individuals' gender identity presentation congruency, so the independent variable that we looked at, and their levels of anxiety, depression, or other general well-being measures. Or that depression could mediate associations between this congruency independent variable and other health outcomes, such as suicide risk. Finally, when it comes to policy implications, local, state, and national policies are warranted to protect those whose gender identity labels are incongruent with their biological sex, especially given the prevalence of increasing anti-trans and drag bills. It's important to not just protect these populations for their sake, but also for these health impacts that we're seeing in this and previous research and the negative impacts that it has. We'd also like to see workplace policies that would provide protection from discrimination in application and work settings in line with this research. So that is our research on how gender expression identity labels relates to minority stress and what we found. Thank you very much for listening. We really appreciate it, and fantastic job to everyone who's presented today. Thank you.
Excellent presentation and timely. Thank you so much for sharing your work. Any questions for the students? Anthony.
Thank you very much. Wonderful presentations all around. I was very curious about specifically how you sort of created like the independent variable, the way that you really, I guess, brought together the, I guess, like the, what am I looking for? Like the categorization of the names around your study. I think it'd be very interesting to hear more about.
Yeah, definitely. Julia mentioned a couple examples, such as those who reported biological sex assigned at birth as male, and who identity labels such as twink would be incongruent because twink is traditionally a feminine label. When we were going through the data set, we also selected out anyone who had a combination of masculine and feminine labels. We wanted to look at people who either had just masculine, just feminine, or the androgynous label. Anyone with the androgynous label was categorized as incongruent because androgyny does not fit into the heteronormative expectations of masculine or feminine. And then in terms of those who did not have the androgynous label, it was either all masculine or all feminine that we let pass through. And then if they had all feminine and assigned male at birth, that was incongruent, and all feminine assigned female at birth, that would be congruent, and vice versa. And that was kind of how we separated those labels. So again, butch, bear, and jock were our masculine labels, and femme and twink were our feminine labels.
Thank you very much.
Yeah, any other questions or comments? No, thank you. I really appreciate everyone's participation today. I learned a lot from all three presentations, and I know you all share the same. For the last team of students, make sure you check out the chat. You got some great feedback as well. And we are, we have recorded today's presentations, and so we will be uploading them on the IPHA, the Illinois Public Health Association's YouTube page. So please be on the lookout for that. And for the students, please make sure you share that link on your resume CV, so include this presentation as part of your role. And I'd like to thank everyone for all their time and attention in preparing the presentations. And here's to a successful second annual research symposium for the students in IPHA. So thank you all very much. And for those that are still in school, we'll be offering it again next spring. And for those professors and faculty that are on the, on this presentation too, please be on the lookout. We'd be happy to share more research, especially there's great follow-up research from all the presentations. So thank you all very much. For students, good luck with final exams and as you end the semester, and have a great day and week.
Thank you.
Thank you.
Thank you.
I just wanted to say thank you again, Beth, for the opportunity.
Welcome. No, this was a really great presentation, really important work that you're doing. So great job. So thank you for sticking your neck out and doing it. That's fabulous. Thank you.
Have a lovely day.
You too. All right. Bye-bye.